Hello, and welcome to the Kayal Orthopedic Center podcast. I can't even begin to tell you how honored, privileged, and blessed I am to have today's special guest, board-certified orthopedic surgeon and member of the Kayal Orthopedic Center, Dr. Edward Friedland, as my first guest on the Kayal Ortho podcast. Dr. Friedland came out of the United States Air Force in July of 1968 and started clinical practice on August 1st of 1968. Now keep in mind, I was 8 months old at the time. Dr. Friedland served as the general surgeon in the United States Air Force and was chief of surgery at McConnell Air Force Base from January 1967 to June 1968. Believe it or not, Dr. Friedland will turn 86, God willing, and on July 31st, 2023, he will have been in practice for 55 years. Wow. God bless you, Dr. Friedland, and thank you so much for your service to this country.
Thank you.
Thank you. Thank you for being here with us today. Let's first start out by asking Dr. Friedland to tell us about his formal education and training in the field of orthopedic surgery.
Actually, my most valuable educational experience was before any of this. My high school, I went to the Bronx High School of Science, which is a school very heavily focused on science and mathematics. While there, most people are on sports teams, I was on the math team. I went on to NYU Uptown, which was in the Bronx where I lived, and majored in mathematics. Science was a minor. Psychology was a minor too. And when I finished, I was initially looking for a career in math. Unfortunately, or fortunately, as it turns out to be, there were no really good careers in math. Computers filled rooms, not microchips. And it was a very infancy industry. The only real career in math was as an actuary for insurance companies, and that would involve living and working with numbers the rest of my life. I really wanted a field that would involve me more in being with people, working with people, helping people, and that just didn't appeal to me. So I applied to medical school and went to medical school. I went to the State University of New York Downstate Medical Center in Brooklyn, after which I went to Maimonides Hospital in Brooklyn for an internship and spent a year as a surgical resident at the Veterans Administration Hospital in Brooklyn. I then went into the United States Air Force, and when I came out, went into orthopedic practice and have been there ever since.
Well, thank God you made that decision, Dr. Friedland. I'm sure I speak on behalf of thousands and thousands of patients in northern New Jersey and the tri-state area that have been so blessed to call you their doctor, and that you made that decision to go into orthopedic surgery. With respect to that, how would you say that your practice, your clinical practice, has changed over the past 55 years or so?
Well, I think the practice of medicine in general has changed, and mine with it. Initially, I was a general orthopedist. In that era, we did everything. We treated and operated on hands, on backs, on shoulders. Whatever needed to be done, we were there. There were no subspecialists. Now, of course, we have subspecialists who can do far more sophisticated and complicated procedures than we could ever have dreamed of. In addition, the surgical procedures that I did in that era are now archaic. We do maybe if we did 10% of these anymore, this would be unusual. Everything is newer and far more sophisticated and gets much better results.
Yes. Along those lines that you're speaking of, where physicians are becoming more and more specialized, the field of orthopedics is becoming more and more specialized, as you have mentioned. I don't know of really too many other doctors that are still practicing general orthopedic surgery. Most of them are fellowship trained specifically in one area, and that's really what they focus their practice on. Along those lines, having been in practice for over 50 years or so, You've witnessed some major orthopedic technologies and breakthroughs over the years. Can you speak about some of those major advancements that you have appreciated over the years, for instance, in the area of sports medicine and arthroscopy and total joint replacement and fixation of fractures, for instance, among others?
Actually, everything you've mentioned is new. Our concept initially, when I was initially in practice of fixation of fractures, was basically you put plates on, you could put rods down. Now the sophisticated methods of treating fractures with external fixators, with compression plates, with dynamics fixation, with even splint fixation, where you don't even put anything in, you allow the splint to really control the fracture, is all new. Arthroscopy was unheard of. Operating on a joint with a tiny little hole, unheard of, unthought of. There was no such thing as joint replacement, elbow replacement, hip replacements, knee replacements, shoulder replacements now, unheard of. Spine, if someone had a herniated disc, we would just go in and take out the disc, take out bone, take the pressure off the nerve. That would be considered the best procedure. Now we can use screws and rods and really do a wonderful job on recreating a stable, functional spine. Mostly every aspect of orthopedics has advanced and evolved over this time.
How would a surgeon, for instance, like yourself, who had no formal training in some of these procedures like hip replacement, knee replacement, or arthroscopy, start to begin to dabble in those fields with the new equipment in order to improve their own surgical skill set so that they can offer the latest and greatest technologies to their patients?
This became a real issue. When you're in active practice, you can't just take off 6 months or a year to go on a fellowship training program. You have to do it literally while you're practicing. So I would assist surgeons who had been trained in arthroscopy and learn how they did it. I would work with them, and then they would work with me, helping me learn until I became proficient in doing the procedure as well. I was able to take a week off and go out to California, where I learned how to do a knee replacement from the man who developed it, Leonard Marmer. And I came back and was able to start to do these in northern New Jersey. In fact, I and one other doctor were the first to do knee replacements in northern New Jersey. It became a matter of learning on the fly and picking and choosing times where you could actually be trained to do this.
Did they have Cadaver Labs back then, like they do today?
Yes, they certainly did. And when I would go to an academy meeting, I might sign up for one of those Cadaver Labs and work on that too, yes.
That's great. We'd hate to think of patients being the guinea pigs, right?
Oh, absolutely.
I remember the days of skeletal traction. Do you remember those?
Absolutely.
You rarely, if ever, see patients treated definitively with skeletal traction for long bone injuries and spica casts and things like that. You spoke before, referenced the Sarmiento type fracture brace, which is rarely used anymore. Surgeons are becoming more and more aggressive as technology improves and are leaning towards treating things that were traditionally treated very well and successfully non-operatively, now being treated with surgical intervention because of technological advancements. In general, as we know in our field, we like rigid fixation and early mobilization. So a lot of times when we can perform operations in a minimally invasive manner, achieve rigid fixation to allow that joint or patient to mobilize early, those are some of the major advantages to surgical intervention. Faster healing, lower risk of complications from being sedentary and immobilized, less stiffness, and improved function and return to function in general. So, certainly the vendors, the companies out there have helped us help our patients get better faster. And the field continues to evolve, and it's something I very much appreciate in our field of orthopedics. On that note, considering how surgeries and technologies have changed over the years, can you speak a little about length of stay? I remember the days when I first came out where total knees, for instance, would be admitted to the hospital for a minimum of 3 days, often up to a week. We'd round on these patients every day. We would get social services involved, physical therapy involved, a case manager involved, the families involved, and we'll discharge them to rehab facilities. Nowadays, that's rarely, if ever, done. Routinely, we're doing at the Kayal Orthopedic Center, routinely we're performing outpatient shoulder replacements, hip replacements, knee replacements, ankle replacements. Patients are often home in the luxury of their own environment within 4 hours of surgery, walking around, moving around, and very functional. Rarely, if ever, do we send anybody to a rehab facility anymore. Can you speak to some of those changes that you've seen over the years with regards to length of stay?
Oh, absolutely. When I initially was in practice, the concept was let the person lie around until they heal and don't risk damaging what you've done. So if we took out a meniscus, we'd have the patient in the hospital for a week until they could raise their leg in the air. The leg was in a cast at the time or in a brace, which kept the knee from moving at all. And then at the end of the week, the person left the hospital. They were pain-free, but for that week, they had used nothing of their muscles, and they were probably worse off than they were right after surgery. With their backs and their necks, same thing. Treatment of choice of a herniated disc in the neck or the back was traction. Traction for a week in the hospital. Lying in bed for a week, their muscles became more weaker, they became less functional, and they came out, again, no pain, but physiologically far worse than when they went in. All this has evolved. People are not admitted for traction anymore. They're started on a rehab program to get them back to function as quickly as possible.
That's incredible. It's just to think about the financial impact that had on this country, the cost of healthcare. Clearly, it's obvious to us all now why healthcare in this country is in a crisis, where there have been year after year after year declining reimbursements, where unfortunately physicians are suffering from increased overhead year after year after year. But that must have been incredibly expensive back then. I can understand why we're in a crisis right now. Regarding that, what about the doctor-patient relationship? I can only imagine that the doctor-patient relationship has taken a hit over the years. With all these rules and regulations from the government, HIPAA privacy laws, documentation requirements from insurance companies to obtain eligibility to intervene as a doctor to provide care to our patients, injections, x-rays, MRIs, physical therapy, surgery. All of these have greatly impacted our time with the patients. Years ago, the government enacted these rules and regulations and laws about having an electronic health record. I see doctors and physician assistants spending more time documenting notes as opposed to having face-to-face interactions with our patients. Clearly, that has deleteriously impacted our ability to forge a strong relationship with our patients that's built on trust, respect. I think physicians used to enjoy a much greater reverence than they do today from the patients. Nowadays, unfortunately, in many practices, patients are just a number. Doctors are doing high volume to try to keep up with the costs to run a practice because of these demands. patients are seeing more and more second opinions and third opinions because there is no doctor-patient relationship. Years ago, what the doctor said was worth everything to that patient. The patient trusted the physician. They did exactly what the doctor said. There was a tremendous amount of trust and respect in that relationship. And more than likely, it's probably led to less risk of malpractice claims because doctors didn't have to practice defensive medicine. There was a wonderful relationship there where patients understood that medicine was not an exact science and that we all took the Hippocratic Oath to do our best to take care of these patients. How have you seen changes in that doctor-patient relationship yourself over the years? Because I remember even 25 years ago, you and I were walking around the office in Ridgewood, dictating very short notes, spending most of our time interacting with our patients face-to-face, forging such relationships. And now, most of the time, providers have their backs turned to the patients and they're talking to a computer instead and making sure that they dot every I and cross every T in order to satisfy insurance companies that we can actually bill for this encounter, or provide documentation where the insurance companies will provide authorization to get an X-ray or an MRI or a CAT scan or a surgery or an injection because the eligibility requirements have been met. What have you seen over the years? And would you like to elaborate on that at all?
Well, I've seen exactly what you're describing. When I initially was in practice, you went in, you saw the patient, you spoke with the patient. And the history you get from the patient in the patient's words is probably the most valuable part of the evaluation. It's not, a patient will say, oh, I've got pain in my knee, or I've got pain in my leg. That doesn't really tell you anything at all. First of all, you want to know what type of pain. Is it a sharp pain? Is it a dull pain? You want to know whether it's localized to that area or whether it comes down to that area or emanates from that area. Is there any associated weakness, numbness? There are all different things which give you a major clue as to what's going on with the patient. Most of the time, by the time the patient has told me their symptoms, and I've listened and I've questioned them relative to their symptoms, I know what's the matter with them even before I examine them, because most conditions have a very clear pattern of how they present themselves. Nowadays, the doctor is so pressured that they have no time really to do this because they're going to have 5 or 10 minutes of paperwork filling out forms when they're done, and there are more patients waiting. The volume of patients hasn't decreased. If anything, it's increased. So the amount of time you can give any given patient with any given problem has greatly diminished. So where does it get cut off? It cuts off in the history. You have pain in your leg? Fine, let's take a look. That doesn't really do much in the way of diagnosing what the person has. So there's been a huge difference in the ability of the doctor and patient to communicate effectively for treating what people have.
It's quite sad in a way. On the other side of the coin, in our own practice, it's taught us to be much more efficient. You know, we have to be efficient because we can't compromise in healthcare. We can't cut corners. So they're just much shorter interactions with our patients, but we still have to get to the point, listen to our patients, formulate that differential diagnosis and nail it. We can't make mistakes in medicine. It's just, there's very, very little tolerance for that. So it teaches us to be extremely efficient, good practitioners, and still maintain the ability to do high volume and deliver excellent orthopedic care. With regards to what you were describing, you know, we're all taught in medical school that 90% of our diagnoses can be made just by listening to our patients. We're all taught that. And it's something I'll never forget from medical school. And I think about that every single day that I'm talking to my patients and every single day that I'm talking to our physician assistants. I cannot instill that enough in their minds that they need to just listen, because patients know their bodies way better than we know their bodies. And so that brings us to what we all know as healthcare providers, the SOAP note. There's an acronym called the SOAP note. And for those of you in our audience that are listening that don't understand what the SOAP note means, the S stands for subjective, the O stands for objective, the A stands for assessment, and the P stands for plan. So when we interact with our patients during a doctor-patient relationship, during that encounter, we're taught to have the patient present their subjective complaints. First, they'll offer us their chief complaint, what's bothering them today. And then they'll discuss with us the history of the present illness. Today, Dr. Kayal, I'm here for my right knee pain. I injured my knee playing soccer over the weekend with my son. I heard a pop. It swelled immediately. I fell to the floor. I couldn't get up and walk on it. It's been swollen ever since. It's been very, very painful, and it's been feeling rather unstable. I've been icing it over the weekend, and I'm here to get this thing evaluated because it's really uncomfortable and stiff. So that's an example of a history of the present illness where the patient is giving us the story behind how the injury occurred, what made it better, what made it worse, and why they are here today. The next part of the acronym is the O, the objective examination, where a physician like myself will perform a physical examination where we'll focus and hone in that body part that patient is complaining of. We'll do specific physical examinations that are focused on coming up with a diagnosis. All along, as we're listening to the patient's history of present illness and doing our physical examination, we're formulating in our own minds a differential diagnosis. It's probably this, this, or this. The objective part of the physical examination is further backed up by imaging studies. Imaging studies can include X-rays, CAT scans, MRIs, bone scans, etc., laboratory work, etc. And then finally, we get to the A and P portion of the SOAP acronym. The A is where we make our final assessment, and our P is the plan. What are we going to do to address this medical condition? So this sort of brings me to my next question to Dr. Friedland. We've spoken earlier today about technological breakthroughs and advancements in the field of orthopedic surgery. One of those major advancements comes in the way of advanced cross-sectional medical imaging, such as CAT scan and MRI. And I'm curious to know, Dr. Friedland, when this technology was introduced into your practice and how it impacted your ability to make these definitive diagnoses.
Well, when I initially went into medicine, the only radiologic studies you had relative to orthopedics were X-rays, pure and simple. You could get if you were looking for a herniated disc in the back, you would need special spinal X-ray called a myelogram. But what did a myelogram involve? It involved initially, when I first went into practice, injecting lepiodol, an oil-based dye, into the spinal canal, which you couldn't leave there. So after you've got your X-rays, you had to take it out again. And that wasn't so easy, and it wasn't so painless. In fact, it was often as painful as any surgical procedure you would do afterwards. Eventually, that was replaced with an aqueous solution, which made it easier to get out without hurting the patient. But at the same time, this was still crude. It was invasive. Now, we went on to CAT scans. You did not need to put any dye in. And with MRIs, you certainly did not need to put dye in. A CAT scan, we thought, was a fantastic improvement because you could now see inside with what are basically slices, which would give you precise imaging of what you were looking at. And then the MRI came and made the CAT scan look primitive because the MRI gave a far more sophisticated imaging of different tissues. Then the various improvements in MRI, such that now the 1.5 and 3 Tesla MRIs give you such good definition that the early MRIs look like Rorschach tests. You can read anything you want into them. So the sophistication of radiology has come a huge way. If you're concerned about tumor, you can't see it on an X-ray unless there's been approximately 40% destruction of bone. Now with an MRI, you can see it even in its earliest stages when you're at a curable stage and where you can get it out and get rid of it either by surgery or radiation or chemotherapy, whatever, long before it has reached a life-threatening situation. So the advances are absolutely enormous.
Incredible, incredible. I couldn't imagine practicing today without this high-resolution cross-sectional imaging that we have available to us. I can only imagine that in the past, you either treated patients way too conservatively when they really could have had a surgical operation to fix their problem, but without the ability or the technology to formally make that diagnosis, those patients were treated all too conservatively without much relief. Or, on the other side of the coin, potentially, you had to do more and more exploratory operations because you thought maybe the patient had a meniscus tear or thought maybe the patient had an ACL tear or a rotator cuff tear or a labral tear, but you didn't have any imaging modalities to confirm that.
100% correct.
So it just, both of them in both formulas leads to and yields bad patient care.
Yes.
So thank God for this improvement in orthopedic technologies, which actually makes me think a lot of the arthroscope as well, because the arthroscope, at least if you're going to do a procedure, you're not filleting the patient open. You're not filleting that joint open just to put your eyes in there to explore to see if the patient has this torn or that torn. Nowadays, and with the introduction of the arthroscopy, through tiny, minimally invasive puncture sites, it afforded us the ability to put this long arthroscope into a joint to look inside the joint with high-resolution imaging abilities to do sometimes what we would call a diagnostic arthroscopy. Now even diagnostic arthroscopies are rarely, if ever, performed because the high-resolution cross-sectional imaging is so good that we have, for the most part, the ability to make definitive diagnoses before proceeding with surgical intervention, even with the arthroscope. So technology is an amazing, wonderful tool that we use in orthopedics, and believe it or not, it continues to evolve day after day after day in this amazing field of orthopedic surgery. I'm just going to shift gears a little bit, Dr. Friedland, right now. I'm curious to see how you feel about the evolution of the medical practice model in orthopedics. Years ago, clearly everyone would finish their training, their residency, their fellowship, and for the most part, either go into academic medicine, where they are heavily interested in research at academic institutions in the field of orthopedics, or they would go, for the most part, into solo practice. You would be a solo practitioner, you'd start your own business, you would work hard, take a lot of call, build your name and reputation and patient loyal following. Nowadays, you don't really see much of that anymore. These doctors that are finishing up are for the most part, joining health systems or large, very large groups in employment models. The days of the solo practitioner or the practices where there's 1, 2, or 3 orthopedic surgeons in those groups, virtually non-existent anymore. The philosophy is, and this really goes back to our prior conversation, the philosophy is, we need to have strength in numbers. We need to have leverage against hospital systems, against insurance companies, and the only way we can negotiate good rates so that we can actually get paid well for what we do, because overhead continues to increase. One thing I'm interested in is how you feel that medical practices have changed over the past 55 years of your own practice. What I envision is a world where 50 years ago, doctors would go into, for the most part, solo practice, or they would join one or two man groups. Nowadays, it appears that we don't see that much at all anymore. It seems like physicians are finishing up and they're joining large health systems, either academic institutions focusing on research, or large health systems, or a very, very large group. Unfortunately, it's a world where we need to have strength in numbers. Medicine is a business as well, as you know, and we need to survive. We need to pay our bills. We need to pay our employees. And as we've discussed over and over again today, reimbursements from insurance companies and the government continue to decline, but overhead continues to rise year after year after year. And so we need to be able to have the ability to negotiate with insurance companies to get reasonable rates for the services we provide. And you just can't do that as a solo practitioner, or if you're in a group with one or two or three other healthcare professionals. Have you appreciated this change over the years?
Absolutely. When I first went into practice, most of us were fiercely independent. We really wanted to have our own practice. In fact, the man I initially went with, ultimately went with, I initially said no to. He asked me to join his practice. I said, no, I want my own practice. And then after we talked a little more, I reconsidered and joined him and never regretted it. He was a wonderful, wonderful person, a pleasure to work with. But over the years, it's been clear that this is not the answer to the current modern medicine. Orthopedics in particular has different parts of the body. When I was first in practice, I was a general practitioner of orthopedics. I treated hands, backs, necks, knees, hips, ankles, feet. There were no specialists. Now there are specialists. And they can do sophisticated procedures that orthopedists who do general orthopedics are not trained to do. There's no way you can be a specialist in all parts of the body. There are many sophisticated diagnoses for different parts of the body and sophisticated surgeries that can only be done by someone who can do this again and again. Most procedures, no. Most aspects of orthopedics can be done by generalists, but specialists bring a special talent from special training, and they are needed above and beyond the individual general practitioner of orthopedics.
I agree with that. With regards to the medical legal aspects of medicine and the, as we all know, fairly litigious society we live in this day and age, have you appreciated changes in that regard as well? I can only imagine that years ago, when doctors invested so much time in forging that strong doctor-patient relationship built on trust, I would find it hard to even imagine that if a patient would consider suing a physician. Nowadays, because that relationship is not there, and sometimes patients feel neglected, the doctor didn't spend enough time with me, they often get second and third opinions, and it seems like there's no tolerance for any result less than perfect because of the world we live in. Is that something you've appreciated? Are you seeing doctors over the years practice more and more defensive medicine for fear of being sued because insurance companies are requiring us to spend so much time documenting things and spending more time on the computer and the medical record, filling out forms and paperwork, as opposed to investing our time and energy in our patients with face-to-face interactions?
Well, I think that's absolutely right. I think that when I initially went into practice, we spent our time speaking with patients, developing relationships. We inquired. We knew more about our patient than just their knee or their ankle. We had an understanding of what their needs were. And when we treated them, we focused on getting the result they needed. The result one person needed may have been very different from the result the next person needed. Now, it becomes a matter of time. The volume of patients has not changed. If anything, it's more, but the time is less. If you have to spend 5 to 10 minutes per patient doing paperwork after the person leaves, there's no way you can give that same amount of time to that patient without curtailing the treatment or time you give the next patient. It becomes a matter that it cuts into the time of every patient, and this becomes an impossibility as far as maintaining the kind of relationship and developing the kind of relationship you really would like to. Yes.
Yeah, it's sad. I know,
I take it a step further. You mentioned defensive medicine. Doctors now, because of the lack of close relationship, wind up doing more of what we call defensive medicine. There are many, as you know, there are attorneys out there who go out of their way to advertise their ability to sue for anything that is not exactly perfect. And therefore, if you're treating someone, you order everything possible that you might possibly be asked to order, even if you don't really feel it necessary and you know it isn't necessary. You're in a situation where if the person does not get a perfect result, you're going to be asked, why didn't you order this? Why didn't you order that? Don't you care about your patient? Et cetera, et cetera, et cetera. So there becomes a huge amount of defensive medicine, a huge amount of unnecessary testing, and a huge increase in the cost of medical care.
Yeah, it's sad, the direction that healthcare is heading right now. Do you feel that there's any fix to this? Do you see it changing?
Not in the near foreseeable future, no. There's been no tendency in general public political life, as far as I can see, of correcting or remediating this type of situation. We have a very open society. Litigation is considered everyone's right, and it's certainly not discouraged by the attorneys who make their living from litigation. And I do not really see any change in the foreseeable future, no.
Yeah. On that note, what advice then would you give physicians that are going to medicine and about to embark on a life of interacting with patients on a daily basis? What is the best advice you can give that physician to help him or her become a better physician, to try to resuscitate that doctor-patient relationship that seems to be becoming weaker and weaker and weaker year after year after year as more requirements and tasks are put on our shoulders to comply with insurance companies and governmental requirements in order to be able to actually bill for the service that we just provided to our patients?
Well, I think it comes back to a very old expression, one of the oldest: do unto others the way that you would have them do unto you. Treat the patient as though you were the patient. How would you want to be treated? What would you expect your doctor to say or do to get you better? And then you do that for your patient. I think that's the only way you can really do your patient justice and do yourself justice.
And then how about to the patient that's about to go see a doctor? What advice would you give that patient to make sure that they're in the right hands?
The advice I would really give a patient is be your own advocate. Understand that you are the person needing the care. Make sure your doctor understands why you're there, what is bothering you. Make sure that the questions that he or she is asking and the tests he or she are ordering are aimed towards meeting your needs. If you cannot get that feeling, if you cannot redirect him or her so they get that feeling, change doctors.
Good advice, good sound advice. So, look, clearly you've been with us for 55 years in practice. Over those years, you've developed an incredible expertise in the field of medicine. You've developed a tremendous amount of experience and wisdom. I want to take advantage of this opportunity that we have with you today so that we can try to glean from you some of this wisdom that you've gained over the years. What is something that you can share with us, junior physicians, that we can just remember you by and remember for the rest of our years in practice? Because we all took the Hippocratic Oath. We all took a vow to, do no harm to our patients and to be the best physicians we could be. I hope that most, if not all of us, have gone into this field for the right reasons, to care for patients because we love people and we want to help them and we're compassionate and empathetic. What advice would you give our healthcare community of physicians, not only at Kayal Orthopedic Center, but around the world?
I think the advice I would give you is to remind you that it is a privilege to have the opportunity to do what we're doing. We are given the opportunity to help people, to achieve success in enhancing people's lives. And that very few people are in that kind of situation where we can accomplish something, and something which will carry on in our patients and their families and so on too. And that, again, as I said before, the so-called golden rule does apply. Just remember, do unto others as you would have them do unto you. Treat your patients like you yourself would want to be treated.
Wow, those are amazing words of wisdom. And I must say it's been an honor and privilege and pleasure to interview you today for our first podcast. And not only to interview you for our first podcast, but to work alongside you for the past 25 years at the Kayal Orthopedic Center. You know how I feel about you. I highly respect you and admire you. And, you've been a mentor to me my entire career and to many other physicians at our practice. Your work ethic is impeccable, like no other I've ever seen. And you've just been a blessing to me in my life and to our practice and to thousands and thousands of patients in northern New Jersey. There's no one else I'd rather have on my first podcast here at the Kayal Ortho Podcast, and I will treasure this video for the rest of my life, and I hope that your family, your wife, and your children, and your beautiful grandchildren will also treasure it the rest of their lives as well, because you've had a tremendous impact on medicine in general, and especially orthopedic surgery in northern New Jersey and the tri-state area here. And it's been an honor, privilege, and blessing to spend this time with you. So thank you so much, Dr. Friedman. Thank you.